Hi, I'm Dr. Akhtar Amin and today's topic is non-neoplastic lesions of the eyelid. After that we will cover malignant lesions of the eyelid. The first one is lesion, also known as meibomian cyst. It is a firm, rubbery, slow-growing nodule and it is caused by the obstruction of the meibomian glands and it is known as deep lesion. And if there is obstruction of these glands, it is known as superficial lesion, and this is the lesion. So this is a normal eye and this is upper lid meibomian gland. Again here you can see meibomian gland. It is present in the tarsal plate, and here you can see the glands of these. Glands of these obstruction also cause lesion. Pathophysiology: there is obstruction of meibomian or these gland, after which there is lipid breakdown products and they accumulate and they leak into the surrounding. Here you can see they leak into the surrounding and there is granulomatous inflammatory response. This is a sterile inflammation, and this sterile inflammation distinguishes it from the hardyolum or stye, which is non-sterile. Location on the eyelid is dependent on which gland is obstructed. If meibomian gland is obstructed, inflammation will be on the conjunctival portion. If this gland is obstructed, inflammation will be on the skin side. Here this is blocked meibomian glands and the others are normal. So pathology, again, lipogranulomatous inflammation. There is neutrophil, plasma cells, lymphocytes, epithelioid histiocytes and multinuclear giant cells. Epidemiology: it is the most common inflammatory lesion of the eyelid. About 13.4% all benign lid lesions are lesions. There are a lot of risk factors such as poor lid hygiene, stress, blepharitis, eyelid trauma, surgery, conjunctivitis, viral, in which case it can cause recurrent lesion in children, hardyolum. Systemic factors are seborrheic dermatitis, rosacea, hyperlipidemia, tuberculosis, immune deficiency, and malignancy. Malignancy can be disguised as recurrent lesion, especially in the elderly. If there is recurrent lesion, so it can be a sign of malignancy. Clinical presentation: there will be slow growing rubbery nodule on the eyelid and it may progress to become edematous and can cause erythema. If it is large, it can cause astigmatism and it is more common in the upper lid. Why? Because there are increased number of meibomian glands. It is normally painless, but it can cause mild tenderness if it is in large size. There may be tearing and heaviness, conjunctival erythema, swollen preauricular lymph nodes. So diagnosis is based on history and physical findings. There will be again non-tender nodule, and averting the eyelid may improve visualization. If there is recurrent or persistent lesion, it should prompt further investigation like fine needle aspiration cytology or biopsy to rule out malignancy. Now, what is the treatment? Treatment is oral antibiotics. They are required if there is bacterial infection, and if for sterile, no antibiotic is required. So initially conservative management. Why? Because at least a third resolves spontaneously, so observation may be appropriate, especially if the lesion is showing sign of improvement. And what are these conservative? There should be warm compression. Hot compressive application should be done several times daily. It aids resolution, particularly in early lesions. Expression between two cotton tip applicators. So expression is sometimes effective in expressing the content of a fresh lesion near the lid margin. And steroid injection It is given into or around the lesion, and it has been reported to give similar resolution rates to incision in curettage. It is preferred for marginal lesions and lesions close to the structure such as lacrimal punctum because the risk of surgical damage to the punctum. The regimen includes 0.2 to 2 ml of triamcinolone acetonide aqueous suspension diluted with lidocaine to a concentration of 5 mg per ml, and usually 0.1 to 2.2 ml of 40 mg per ml is injected with 27 gauge or 30 gauge needle. Success rate following one injection is about 80%, so a second can be given after 1 to 2 weeks. Local skin depigmentation can occur in fat atrophy, but they are uncommon complications and they are less likely if a conjunctival approach is utilized. Retinal vascular occlusion is also described as a rare complication. Incision in curettage is the surgical option. Local anesthesia is given. The eyelid is everted with a specialized clamp. The cyst is incised vertically through the tarsal plate. It is important that incision should be given vertically on the tarsal plate and the contents are curated. Limited excision of solid inflammatory material is sent for histopathology with fine scissors. It may be helpful in some cases if there is no focus of secretions. Suture should not be used. Topical antibiotic is used 3 times daily for 5 days following curettage. For marginal lesions, they can be managed by steroid injection, by curettage of associated deeper lesion, by shave curettage, by incision in curettage via horizontal incision on the conjunctival surface or vertically through a gray line. Prophylaxis treatment of blepharitis, for example, daily lid hygiene. Systemic tetracycline may be required as prophylaxis in patients with recurrent lesion, particularly if associated with acne rosacea. Differential diagnosis are hardiolum, which is tender, blepharitis, and there is there is itchy eyelids and there are scales on the sebaceous carcinoma. It is round and painless. Other eyelid cyst of mole. So cyst of mole arise from the sweat glands. Sweat glands are found on the eyelid margin, and this is the gland of mole. You can see in the picture. So you can see they are dome shape and they are filled with clear fluid, and that's why it makes the trans illumination a key feature. In this picture you can see it is trans illuminated, while the cyst abscess it is not trans illuminated. Here you can see this is cyst abscess. It is formed by blocked sebaceous glands in the eyelid margin. There are yellow eyelid secretions, do not trans illuminate. The other one is xanthelasma. Plural is xanthelasmata. It is a common and frequently bilateral condition. It affects middle-aged and elderly individuals. It is a subtype of xanthoma. Hyperlipidemia is found in about 1/3 of patients. In these patients, corneal arcus may also be present. Here you can see in the picture corneal arcus. In contrast to chalazion, there is fat in the xanthelasmata. It is intracellular with lipid-laden histiocytes, form cells in the dermis. There are histiocytes, lipid-laden cytoplasm cluster around the cells. Treatment options are surgical excision, simple excision, where adequate excess skin is present, and if excess skin is not present, then micro dissection. The flap is raised, the fatty deposits dissected from the skin under surgical microscope, and the skin is replaced. Other methods are chemical peeling with bi or trichloroacetic acid. And laser ablation and cryotherapy have advantage but may be more prone to scarring, including pigmentary changes. Another one is epidermal inclusion cyst. Epidermal inclusion cyst usually caused by implantation of epidermis into the dermis following trauma or surgery. It is a slow growing round and firm superficial or subcutaneous lesion, and it contains keratin. And this another one is sebaceous cyst at the outer canthal region, sebaceous cyst at inner canthus. Another one is melia are caused by occlusion of pilosebaceous units. Result in retention of keratin. They are tiny, white, round. Superficial papules that tend to occur in crops. Another one is dermoid cyst. It is usually subcutaneous or deeper. As you can see, deeper and subcutaneous, and is typically attached to the periosteum at the lateral end of the brow. It is caused by skin sequester during embryonic development. So it is a small lump under the skin from the nest of embryonic epithelium left between fetal lines of closure. It may be deep within the orbit, superficial adjacent to the orbital rim. So there are anterior dermoids. They present in the first decade and deep dermoid present in adulthood. The symptoms: the anterior lesions, there is fullness on the lateral orbital rim. A deep lesion are painless, and there is progressive proptosis and diplopia. Treatment is surgical excision in nearly all cases. Goal is to removal of cyst intact. Surgical approach depends on the location of the lesion and affected adjacent structures. Thank you.